The topic for this lecture is multiple pregnancy. I am Professor Olusola Fashuba from the Department of Obstetrics and Gynecology, College of Health Sciences, Obafemi Awolowo University, Ile-Ife. Yes, at the end of this lecture, you must be able to define and classify multiple pregnancies and know the types and diagnosis of twin pregnancy. You should be able to determine the zygosity of multiple pregnancies and be able to make a list of complications involved in multiple pregnancy and be able to describe the management of twin pregnancies and pregnancies of higher orders. Multiple pregnancy is the simultaneous intrauterine development of two or more embryos. Simultaneous intrauterine development of two or more embryos. When two fetuses develop simultaneously, it is termed twin pregnancy or twin gestation. When there are three fetuses, they are described as triplets. 4 fetuses as quadruplets, 5 fetuses, quintuplets, and so on and so forth. The incidence of multiple pregnancy is increasing globally as a result of delay in childbearing for various reasons and as well as due to advancement in assisted reproductive technologies. These two reasons account for the increasing incidence of multiple pregnancy worldwide. Delay in childbearing for various reasons, including career and effect of education, then advances in assisted reproductive technology. What is the incidence of multiple pregnancy? Multiple pregnancy constitutes about 3% of all births. It constitutes about 3% of all births. And approximately 1 in every 5 successful IVF procedures result in multiple pregnancy. Approximately 20% of successful in vitro fertilization procedures result in multiple pregnancy. The incidence of twin pregnancy varies worldwide, with the highest incidence of as high as 45 per 1,000 births in southwestern Nigeria. Intermediate incidence amongst Caucasians, and then the lowest incidence of 6 per 1,000 births in Japan. Japan has the lowest incidence of about 6 per 1,000 births, while Nigeria, in southwest Nigeria, has the highest incidence, about 45 per 1,000 births. The incidence of spontaneous triplet pregnancy, triplets, 3 fetuses growing at the same time, is about 1 in 6,000 to 8,000 births. It's about 1 in 6,000 to 8,000 births. According to Ellin's rule, the incidence of spontaneously conceived multiple pregnancies is this ratio 1 in 80 n-1, where n is the number of fetuses. So the incidence of twins is therefore 1 in 80. And triplets is 1 80 squared, that's 1 in 6,400 births. And that of quadruplets is 1 in 80 to power 3. So 1 triplet to 512,000 births and so on, using the Ellin's formula. How do we classify multiple pregnancy? Multiple pregnancy may be classified based on 1, the number of fetuses present, twins, triplets, quadruplets, quintuplets, and so forth. the number of fetuses, twins, triplets, quadruplets, and so on. Then the number of fertilized ova. Number of fertilized ova. How many oocytes are fertilized? So with that, you can talk of zygosity. Zygosity. So we can have either a monozygotic twin or a dizygotic twin, which I'll explain more when we go ahead in this lecture. Then we can also be based, calculation can be based on the number of placenta present. And this will give you the chorionicity. Chorionicity. And this placenta, the number of placenta, the chorionicity, determines the obstetric and prenatal outcome. The placenta, the number of placenta present determines the obstetrics and prenatal outcome. And lastly, the number of amniotic cavities present. The number of amniotic cavities present. So, invariably, multiple pregnancies are classified based on the number of fetuses present, the number of fertilized ova, the number of placenta, and number of amniotic cavities. Types of twin pregnancy, type of twin gestation. Twin gestation may be dizygotic in about 70% of cases, or monozygotic in about 30% of cases. The dizygotic twins are referred to as non-identical or fraternal twins, and usually they will occur from fertilization of two oocytes. They result from fertilization of two oocytes, resulting in dichorionic diamniotic twins, where each fetus has its own placenta and amniotic cavity. So dichorionic diamniotic. Dichorionic diamniotic. Different placenta for each fetus and different amniotic cavity. There is a variant, two variants of these dizygotic twins. When fertilization of two different ova released in the same menstrual cycle by different acts of coitus within a short period of time is called superfecundation. Fertilization of two different ova released in the same menstrual cycle by different acts of coitus within a short period of time is superfecundation. A woman may have sex on Monday, one ovum is fertilized, maybe another 3 days time, another ovum is fertilized by a different act of coitus. When this type of situation occurs, we call it superfecundation. Superfecundation. The second variety of it is what we call superfetation. Superfetation is the fertilization of two ova released in different menstrual cycles. Like in the month of July, one ovum may be fertilized, and in the month of August, one ovum is fertilized, and both develop intrauterinally and grow. So this phenomenon is called a superfetation. On the other hand, monozygotic or identical twins result from the fertilization of a single oocyte with subsequent division of the zygote. Monozygotic or identical twins result from the fertilization of a single oocyte with subsequent division of the zygote. The chorionicity and amniosity of the monozygotic twin depends on the timing of division of the zygote. So the chorionicity and the amniosity of the monozygotic twins depends on the timing of division of the zygote. Worldwide, we'll talk about dizygotic twins before we talk about the monozygotic twins. Worldwide differences in twinning rates are due mainly to differences in the rates of dizygotic twins. The worldwide differences, the variations in the twinning rates across the globe are mainly due to the differences in the rate of dizygotic twins, which is affected by so many factors. It's affected by so many factors. The first is increasing maternal age. Increasing maternal age. The highest incidence occur between 30 and 39 years, presumably due to rise in follicle-stimulating hormone. In areas where dizygotic twins are common, many of their diets tend to contain a lot of follicle-stimulating hormone. Like in Yoruba area, there is a yam, a yellow yam, that is so prominent around these areas, around this region, that has follicle-like stimulating hormone. Race and ethnicity is a common fact. It's also another factor that influences the development of dizygotic twins. Twins are highest in blacks. They are intermediate in whites and least in Asians. Least in Asians. The increasing parity is another, and that increasing parity will mimic the increasing maternal age. Previous history of twin gestation. Previous history of twin gestation gives about 10-fold recurrence risk following a previous dizygotic twins, previous twin gestation. Then a family history of twin pregnancy, especially on the maternal side. A family history of twin pregnancy, especially on the maternal side. We know that inheritance pattern is autosomal dominant. Inheritance pattern is autosomal dominant. Again, use of ovulation induction agents. Use of ovulation induction agents. Clomiphene citrate increases the incidence of dizygotic twins by about 5 to 10%. And gonadotrophins, human menopausal gonadotrophins, human chorionic gonadotrophins, increases the incidence of dizygotic twins by 20 to 40%. As I said earlier, the rising incidence of various assisted reproductive technology, has been shown to increase the dizygotic twin rates. Dizygotic twin rate following recent stoppage of oral contraception also increases the rate of dizygotic twins. So rate is also higher among women who become pregnant soon after cessation of long-term oral contraception. And this is probably due to high rebound gonadotropin secretions. Conception following a long period of infertility. Conception following a long period of infertility many a times may result in dizygotic twins. Then maternal age, maternal size. Large and tall women have an increased incidence of as opposed to small, short women. Maternal size, obesity, and very tall women have an increased incidence of dizygotic twins. Again, it's nice to note that 75% of dizygotic twins may have the same sex, male-male or female-female. Yeah, what are the characteristics of monozygotic twins? The incidence of monozygotic twins remains constant all over the world. It's about 3 to 4 per 1,000 pregnancies. Monozygotic twins. It's about 3 to 4 per 1,000 pregnancies. This rate is constant and is not influenced by factors that affect the dizygotic twins, like the maternal age, family history or previous gestation, previous twin gestation, and so forth, or drugs like gonadotropins and clomiphene citrates. They do not affect the incidence of monozygotic twins. However, it can be increased by assisted reproductive technology. Monozygotic twins are always of the same sex, almost always of the same sex. But in certain extreme cases, monozygotic twins may be of different sexes. But these are very rare. For instance, following fertilization of the oocyte by a Y chromosome bearing sperm, inaccurate duplication of the sex chromosome could result in the loss of Y chromosome in some cells. The embryo that is formed from the cells missing the Y chromosome will develop into a female, 45XO Turner syndrome, while the other embryo developing from the cells that have the Y chromosome will still develop into a male, 46SY. Yes. It can also occur in cases of non-disjunction during spermatogenesis or oogenesis. It can also result from non-disjunction during spermatogenesis or oogenesis. In this way, there could be an extra X chromosome in the zygos. And when division takes place, it can result in monozygotic birth of XY male and XX female. So, one will need to do some extra care in these two respects to be able to distinguish monozygotic twins from a dizygotic twins. But the conditions, these non-disjunctions and fertilization by a Y chromosome bearing sperm, they are very, 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 very rare. Very rare. Monozygotic twins can also share same phenotypic and genotypic characteristics. They share the same phenotypic and genetic characteristics, including blood group. But, however, their fingerprints are different. But their phenotypic and genetic characteristics are similar in all respects. The types of monozygotic twin depends on the timing of division of the zygote following fertilization. The timing of the monozygotic twin depends on the timing of division of the zygote following fertilization. If division takes place within the first 72 hours, this is the two-cell stage. Within the first 72 hours, just have about 2 cells prior to the differentiation of the trophoblast. Division at this stage will result in dichorionic diamniotic twins, with each embryo having its own placenta and amniotic sac. Division within the first 72 hours will give rise to a dizygotic diamniotic twins before the differentiation of the trophoblast. So each fetus in this division, we have a separate placenta and separate amniotic sac. This constitutes 30% of monozygotic twins. This division, that's dichorionic diamniotic twins or monozygotic twins, they have to be differentiated from the dizygote twins where 2 ovaries are fertilized at the same time or at different cycles by assessing the genetic materials. We will discuss this later. If division takes place between 4 to 8 days, this is the highly blastocyst stage. After differentiation of the trophoblast, then we have the blastocyst stage. This division usually occur at this stage. Division of monozygotic twins almost always occur between 4 to 8 cases in about 70% of cases. It's about 70% of cases. And usually, this one results in monocodonic and diamniotic twins. It results in monocodonic diamniotic twins. In this case, we have a single placenta and 2 amniotic cavities. We have a single placenta and 2 amniotic cavities. When division takes place between 8 to 13 days, yes, if division takes place between 8 to 13 days, then we have what we call monochorionic monoamniotic. There is one placenta, there is one cavity that is present, one placenta and one amniotic cavity. There's a common placenta and a common amniotic sac. This accounts for about 1% of monozygotic twins. This accounts for about 1% of monozygotic twins. Division between day 13 to 15, splitting of the embryo. Splitting of the embryo at this time results in what we call a conjoined twin or a Siamese twins. A conjoined twin or Siamese twins. They share the same, they may share a particular body part with each other. For instance, the chest to chest, what we call thoracophagus, or omphalopagus, when the umbilical cord, when they join at the level of the umbilicus, it's omphalopagus. Or sarcophagus, when they join at the back, at the level of the sacrum. So this condition is more frequently seen in females with a ratio of 3 to 1 to male, 3 females to 1 male. The overall survival rate for conjoined twins is approximately 25% because many of them may have surgery for separation. At the time of separation, that is where the problem may arise. The vision after day 15 results in incomplete twinning. Incomplete twinning, as you may have parts of the head not developing or parts of the lower abdomen not developing. And this is one of the reasons why we tend to have some fetal papyraceous or missed twinning or vanishing twinning as the case may be. Division after 15 days results in incomplete twinning. Let's summarize again. Division within the first 72 hours of division will result in dichorionic diamniotic twins, 2 different placenta, 2 different amniotic cavity. And division between days 4 to 8 will result in monochorionic diamniotic twins. And division between day 13, between days 8 to 12 will result in monochorionic monoamniotic twins. A division between 13 days to 15 days will end up with a conjoined twin or Siamese twins. And if division takes place after day 15, it results in incomplete twinning. And this is what I've just described. The chronicity, zygosity and chronicity can be seen on this figure 1 that is shown here. How do we make a diagnosis of twins? How do you make a diagnosis of twins? History number 1 is from the history of risk factors as earlier outlined. The age of the woman, the parity of the woman, history of drug intake of clomiphene or gonadotropins as the case may be, history of previous twin delivery in the family, or herself having delivered a set of twins or triplets. These are some of the risk factors that are essential. Or a woman who has had some degree of infertility and she got pregnant, or a woman who has had assisted reproductive technology done. These are some of the risk factors for diagnosis for dizygotic twins, and this must be elucidated in the history. They must be elucidated in the history. So if we have all these risk factors, then when we now have the same history of pregnancy, Once there are exaggerated early symptoms of pregnancy, that is especially excessive vomiting, all symptoms of physiological, all symptoms of and physical changes in pregnancy are exaggerated in multiple gestations. Exaggerated symptoms of pregnancy, excessive vomiting, leg swelling, and all the rest. So when you have them combined with the risk factors, they are enough to suggest that there is a twin pregnancy or pregnancy of higher orders taking place. When you examine and uterus is larger than expected for dates, like if the woman, the last menstrual period shows is 20 weeks, and by the time you are examining and you are getting more than 4 centimeters, getting 24 or 26 centimeters, that is more suspicious of a multiple pregnancy. When you palpate the abdomen, you may palpate multiple fetal folds or parts. Multiple fetal folds or parts. Again, this will also corroborate that there may be more than one fetus present in this abdomen. And when you listen to the fetal heart rate, if you listen to the fetal heart rate, you may have 2 different fetal heart rates, and they may not likely to be synchronous. So there may be a difference of about 8 to 10 beats from one of the fetuses. And once they are not synchronous with the maternal pulse and with each other, this is an evidence that there is 2 or more fetuses present in the uterus. Diagnosis of this can be confirmed by ultrasound. Diagnosis can be confirmed with ultrasound. Again, if I have to repeat, the history of risk factors to twin pregnancies, right? Exaggerated symptoms of pregnancy, combined with greater height of fundus, greater than the gestational age, expected gestational age, more than 4 to 6 centimeters. And then palpating 2 or more fetal folds. And listening to the fetal heart rate that shows a difference of about 8 to 10 beats per minute. These are highly suggestive of twin pregnancies. And what you only need is an ultrasound scan to confirm the two or more fetuses in the abdomen. And again, with ultrasound, you can confirm the chronicity or the amnosity. As I said earlier, the monochorionic diamniotic twins are the most common. They are the most common, particularly in monozygotic twins. And ultrasound will show a thin septum, a thin transparent septum, thin separate septum between the 2 amniotic membranes. And this septum is usually less than 2 millimeters. 2 millimeters. And when there is a dichorionic diamniotic twins, the septum is a bit thicker and opaque. So this may actually give you an insight to the type of chronicity. A very transparent and thin septum, less than 2 millimeters, is more suggestive of monochorionic diamniotic. And when there is diamniotic twins, dichorionic diamniotic twins, you may have an opaque, thick, greater than 2 centimeter septum between the 2 chorions. Chronicity is determined on ultrasound, ideally. Chronicity is determined on ultrasound, ideally between 11 and 14 weeks. Chronicity is determined by ultrasound, ideally between 11 and 14 weeks. And with ultrasound, how do you recognize chronicity? There is what called a lambda sign, twin peak or lambda sign. You can see this. This is the lambda sign. You can see. Looks like an inverted Y. You can see from here down. So when you see this appearance, it's more of a dichorionic diamorphic twins. You can see it. Yeah. And when you see a T sign like the other, like this, you can see a very thin membrane, then this one forms the upper head, T is a T. So this T sign shows a monochorionic twin. This is a monochorionic. And compared, look at this again. This septum is so thick, and is more than greater than 2 mm. This one is less than 2 mm. And this lambda sign is characteristic of a dichorionic diamorphic twin. Yes. The placenta, sometimes the two placenta may overlap in dichorionic twins, making it difficult to delineate them, and thus making it difficult to discern whether it's mono or dichorionic twins. Yes, so it might be difficult to diagnose when you have a dichorionic diamorphic twins when the placentas overlap. Determination of zygosity. Determination of zygosity lies in the fact that if the twins are monozygotic twins, they have the same predisposition to certain medical conditions. And therefore, if, for example, cancer should develop in one of the pairs of the twins, preventive measures must be instituted in order to detect cancer in the other pair. More importantly, in case of organ transplantation, there are unlikely to be problems with rejection immunity. That's one of the advantages. If one has to do a renal transplant or a liver transplant in one of the pairs, and they have to use the organs of the other, rejection is likely to be possible. Monoamniotic twins are always monozygotic. Monoamniotic twins are always monozygotic. So also is monochorionic diamorphic twins. When you see monoamniotic twins, they are more likely to be monozygotic, or monochorionic diamorphic twins. They are more likely to be monozygotic. If the fetuses are of different sexes, male and female, they are likely to be dizygotic. Then they are zygotic. Placenta examination following delivery. If a single placenta is found, monozygotic twins is most likely. If a single placenta is found following examination of the placenta under a running water, monozygotic twins is almost likely. It must, however, be borne in mind that the two placenta in dichorionic twins may be fused and appear as a single placenta. So, sometimes the two placenta in dichorionic twins may be fused and appear as a single placenta. And this is why sometimes it may be difficult for ultrasound to pick the placenta of the dichorionic twins because of the overlapping. Other laboratory tests that could be done to distinguish between dizygotic twins and monozygotic twins are the blood group, the ABO typing. ABO blood group typing is one, because with monozygotic twins, they are likely to share the same blood group typings. Their DNA analysis is very important, and they will share the same DNA. Histological examination of the specimen of the intertwin membrane may be necessary to ascertain zygosity. However, as I've said earlier, their fingerprints are likely to be different. If you do the fingerprints and they are different, we may have to resort to DNA analysis or the blood group typing. Yes, so far we have talked about the chronicity and diagnosticity of twin pregnancies, and we have talked about the risk factors and how to make a diagnosis. Now, what are the complications of twin pregnancy? What are the complications of twin pregnancy? Complications could be maternal or could be fetal. Complications of twin pregnancies could be maternal or fetal. Complications of twin pregnancy is about 5 times higher than that of a single-T pregnancy. Complications of twin pregnancy is about 4 to 5 times higher than the risk involved in single-T pregnancy. One, the first complication that is common and unique is the level of anemia. Anemia is about 2 to 3 times more common in multiple pregnancy than in single-T pregnancy. And this is due to increased demands of the fetuses on maternal iron and folate stores, as well as increased physiological hemodilution. Physiological hemodilution that occurs in pregnancy. Increased demand of iron and folate from the mother and increased physiological hemodilution. All this tends to give rise to physiological anemia. And if the level of iron store is not enough, then this anemia gets worsened. Urinary tract infection is at least twice as common compared to single-T pregnancy, urinary tract infection, due to ureteric dilatation, secondary to higher serum progesterone and uterine pressure on the ureters. Urinary tract infection, very common, twice as common compared to single-T pregnancy, due to ureteric dilatation, secondary to high level of serum progesterone and pressures of the uterus on the ureters. Preeclampsia occurs about 10 times more often in multiple pregnancy than in single-T pregnancies. Eclampsia occurs up to 10 times more often in multiple pregnancy than in single-T pregnancy. Preeclampsia, in this case, may occur earlier than 20 weeks and may be more severe than what we have in single-T pregnancies. Gestational diabetes mellitus. Gestational diabetes mellitus. The incidence is much higher in multiple compared to single-T pregnancy. And this is not surprising because of the large size of the placenta or placentae and the placental origin of the human placental lactogen, which causes insulin resistance. When we have one placenta, the level of human placental lactogen, HPL hormone, is not as high as that of multiple. And with this high level of human placental lactogen, it causes insulin resistance. Once there is insulin resistance, the control of blood sugar is effective, and we have excess blood sugar in the capillaries. Placenta previa also occurs. The lower insertion of the placenta in the lower uterine segment. The incidence of placenta previa in multiple gestation is higher. And again, it's because the large placental surface encroaches on the lower uterine segment. The large placental surface encroaches on the lower uterine segment. And that is the reason why placenta previa is so common in multiple pregnancy. Again, we can have placental abruptio. It's also about 3 times as common compared to single-T pregnancy. Placental abruptio, about 3 times as common when compared to single-T gestation. And it can occur, it increases because of the incidence of preeclampsia in multiple pregnation. Or it can also follow intrapartum delivery of the first twin and subsequent reduction in the intrauterine volume. When the first twin is delivered, there is a subsequent reduction in intrauterine volume, and the placenta can just share, and the woman can bleed. So placental abruption is a major complication that can be seen in twin pregnancy. There's an increased risk of operative delivery. Usually due to fetal malpresentation, cord prolapse, or cord accidents, and fetal distress. There's increased risk of operative delivery due to fetal malpresentation, breech, for instance, transverse line, prolapse cord, or cord accident, or fetal distress. All this can predispose to increased risk of operative delivery. There's an increased risk of postpartum hemorrhage. From uterine overdistension, that causes uterine atony and uterine atony postpartum, predisposing to postpartum hemorrhage. What are the fetal complications of twin pregnancy? Increased risk of spontaneous abortion is one that occurs in about 2/3, about 50 to 60% of twin pregnancy. Increased risk of spontaneous abortion. Then you may also have a what we call fetal papyraceous in about 1 in 17,000 to 20,000 spontaneously conceived pregnancies, thought to result from the death of one twin, or amniotic fluid loss, or resorption and compression of the dead fetus by the surviving twin. There may be evidence of a dead fetus, and this can be seen within the first 10 weeks of pregnancy. The risk of the co-twin demise following the death of one twin is about 12% for monochorionic twins and 4% for dichorionic twins. The risk of monochorionic twins is about 18% and 1% for dichorionic twins. Disseminated intravascular coagulation is a rare complication following the death of one of a pair of twins. Another fetal complication is what called vanishing twins. In about 20% of twins, one of the fetuses spontaneously disappears or vanishes. In about 20% of the twins, one of the fetuses spontaneously disappears or vanishes. The prognosis for the remaining twin is very, very good. Vanishing twins. Something that we sometimes see in early pregnancy when an ultrasound makes a diagnosis of twin pregnancy about 8-10 weeks, and by the time you get to 15-16 weeks, one of them might have disappeared. Polyhydramnios is another fetal complication. Polyhydramnios, excessive liquor surrounding the fetuses, is 10 times more common in multiple pregnancy. Congenital malformation is twice as common as in singleton pregnancies. Congenital malformation increases in twin pregnancies. Also for corbillard prevention that is seen in singleton pregnancy can be seen. Neural tube defects, cardiac lesions, all these things are common. Fetal malpresentations are common in multiple pregnancies. Particularly breech presentations. We know that in about 50% of cases, twins tend to present cephalic. In about 50% of cases, twins tend to present cephalic. And in another 33% of cases, twin A may be cephalic and twin B may be breech. 33% of cases, twin A may be cephalic and twin B may be breech. And both twins may be breech in about 10% of cases. And in about 10% of cases, one or both fetuses are in transverse lie. So 10% of cases, one or both fetuses are in transverse lie. And the first twin present cephalic in about 70% of cases and breech about 25% of cases. So fetal malpresentation is a frequent occurrence in multiple pregnancies. Then, because of the over-distension of the uterus, preterm delivery can occur. Preterm delivery can occur, or preterm premature rupture of membranes, or preterm labor can occur. They occur more frequently in multiple pregnancies, and they contribute significantly to prenatal morbidity and mortality in these pregnancies. Preterm delivery, preterm rupture of membranes, preterm labor, they contribute significantly to prenatal morbidity and mortality. Twins deliver averagely between 36 to 37 weeks. Twins, they deliver averagely between 36 to 37 weeks. Triplets, about 33 weeks. And quadruplets deliver usually about 31 weeks. And this as a result of the over-distension of the uterus. Intrauterine growth restriction, where you have a discordant growth diagnosed sonographically in the antepartum, is at least, it occurs more frequently. Discordant growth. One fetus is bigger than the other. One fetus is bigger than the other. And this can be appreciated. For instance, if the biparietal diameter of one is greater by about 5 millimeters. 5 millimeters. Difference between the two. You can talk of discordant twin. Or 5% difference in the head circumference. Or 20 millimeter difference in abdominal circumference. One abdomen is larger than the other one by about 20 millimeters difference. Then you can talk of discordant twin. Growth discordance may be due to any of the following. May be due to any of these following. Twin-to-twin transfusion syndrome. It may be due to twin anemia polycythemia sequence. It may be due to twin reverse arterial perfusion sequence. Again, fetal discordance in multiple pregnancies may be due to twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, and twin reverse arterial perfusion sequence. And this usually occur, these three phenomena occur when there is a vascular anastomosis, or where there is unequal sharing of the placenta mass, where there's an occurring share of one fetus is bigger than other because the one twin is donating blood to the other. And when the first twin is donating blood to the other, therefore the one that is donating blood, is smaller, and the one that is receiving the blood is higher. The one that is having anemia is because of blood loss to the other one, and there may be a compensatory polycythemia, that is taking place in that particular baby. And the twin reverse arterial perfusion prayer is because of anastomosis or a joint cord. In the twin-to-twin transfusion syndrome, also called fetal transfusion syndrome, this occurs in about 15% of monochorionic twins and is responsible for up to 40% of deaths in monochorionic twins. Acute twin-to-twin transfusion syndrome usually occurs during labor, in the interval between the clamping of the cords of the first and second twin. Although twin-to-twin transfusion syndrome classically occurs in monochorionic twins, there are reports in the literature of twin-to-twin transfusion in dichorionic twins, though this is very, very rare. It has been suggested that failure of the mechanism that leads to the inhibition of angiogenesis in the marginal zone of the placenta could lead to development of anastomosis in dichorionic placenta. And fusion of two separate placenta may also lead to vascular anastomosis. The etiology of chronic twin-to-twin transfusion syndrome is the chronic shunting of blood from the donor twin to the recipient twin via vascular anastomosis. The hemoglobin levels for both twins are, however, often not discordant. Arterial anastomosis are protective against the development of twin-to-twin transfusion syndrome. The donor twin becomes hypoperfused, growth resisted, and with associated oliguria and oligohydramnios, whereas the recipient twin is hyperperfused, polyuric with polyhydramnios, and the syndrome is not otherwise called twin oligohydramnios polyhydramnios sequence. The syndrome is otherwise called twin oligohydramnios polyhydramnios sequence because the recipient twin is more polyuric with polyhydramnios, and the donor twin is becomes oliguric as a result of losing much blood to the recipient. The oligohydramnios in the donor twin may be so severe that the donor twin becomes stuck in a position. Hence, the other name of the syndrome, stuck twin syndrome. So, stuck twin syndrome. When you have discordant, it can be twin-to-twin transfusion syndrome. It can also be called twin oligohydramnios, twin polyhydramnios sequence, or a stuck twin syndrome. These are things that are used, you can get in literature. There is a Quintero staging of twin-to-twin transfusion syndrome based on the features that we have just described. Quintero staging of twin-to-twin transfusion syndrome. The stage 1 is oligohydramnios in the donor twin, oligohydramnios in the donor twin, and polyhydramnios in the recipient twin. I've mentioned that. The bladder of both twins in stage 1 is visible on ultrasound with normal Doppler indices. Both bladders are visible on ultrasound with normal Doppler indices. But the only thing you will see is oligohydramnios in the donor twin and polyhydramnios in the recipient. In stage 2 of this Quintero staging is just like stage 1, but the bladder of the donor twin is not visible. The bladder of the donor twin is not visible. The Doppler indices are seen normal. Stage 2. In stage 3, it's as in stage 1 and 2, but with critical abnormal Doppler indices in either twin. But critical abnormal Doppler twin indices in either twin, which include absent or reverse end diastolic flow in the umbilical artery. The abnormal Doppler flow includes reverse end diastolic flow in the umbilical artery, reverse flow in the ductus venosus, and pulsatile umbilical venous flow. 3 indices, 3 abnormal Doppler flows. 1, reverse end diastolic flow in the umbilical artery. 2, reverse flow in the ductus venosus, and 3, pulsatile umbilical venous flow. Stage 4. In addition to stage 3, we have fetal eye drops in either twin. There could be fetal eye drops in either twin. Usually, the recipient twin is the one that becomes eye drops because of the large size and polyhydramnios. In stage 5, in addition to stage 4, there is demise of one of both twins. In addition to stage 4, there is demise of one or both twins. Usually, the donor twin dies first. Usually, the donor twin dies first. In general, the prognosis is better in early stage disease, stages 1 and 2, and worse in more advanced cases from stage 3 and above. And it's always better that an early diagnosis is made so that intervention can occur in twin-to-twin transfusions, twin-to-twin transfusion syndrome before an adverse condition develops. Twin-to-twin transfusion syndrome is severe when it occurs before 26 weeks of gestation. They tend to occur severe, they tend to have more severity when they occur early in pregnancy. How do you treat twin-to-twin transfusion syndrome. One is reduction amniocentesis. Reduction amniocentesis. This involves removal of excess amniotic fluid from the sac of the recipient twin through amniocentesis. It's usually useful in managing milder cases of twin-to-twin transfusion syndrome that we'll call later in pregnancy. The procedure is generally not thought to be effective in managing advanced stages of TTS, stages 3 and 4. Again, another form of treatment is called septostomy, microseptostomy. This is a surgical procedure to create a hole in the membrane between the fetal sacs using a needle to allow movement of amniotic fluid from the sac of the recipient twin to that of the donor twin. There is a risk of the hole between the sacs becoming too large and the entire separating membrane may be disrupted so that the fetuses share the same amniotic sac. The third type of treatment I can offer is fetoscopic laser occlusion of chorioangiophagus vessels. This is an advanced stage of TTS, and the experience is still limited, very, very limited. We can do a selective cord coagulation. And in this type of case, we may have to sacrifice the life of one of the twins. But usually, it is the donor twin that may be sacrificed. And this will stop blood flow through the coagulated blood. Selective fetal reduction may be done in ART. Selective fetal reduction may be done in ART, where you have about 4 or 5 multiple fetuses, and you can easily selectively kill one of them and let the other ones grow, particularly if there are more than 3 fetuses. This is fetoscopic laser ablation. You can see using laparoscope. You can see the fetoscopic laser ablation trying to coagulate blood vessels there. It's possible. But again, these are done in well-advanced countries, not in developing countries. The twin anemia polycythemia sequence is another variant of the twin-to-twin transfusion syndrome. It's another variant of twin-to-twin. And this is believed to be due to the presence of minuscule arteriovenous anastomosis, less than 1 mm. It's believed to be due to arteriovenous anastomosis, which allows slow transfusion of blood from the donor twin to the recipient twin, leading to highly discordant hemoglobin concentrations at birth. Twin anemia polycythemia sequence, usually due to arteriovenous anastomosis, arteriovenous, artery to veins. Criteria for diagnosing twin anemia polycythemia sequence, TAPS, include 1. Hemoglobin concentration discordance between the twins of more than 8 grams per deciliter. Hemoglobin concentration discordance, at least 8 grams per deciliter between the two. Or a reticulocyte count ratio greater than 1.7. A reticulocyte count ratio greater than 1.7 between the two. Or smaller vascular anastomosis, less than 1 millimeters in diameter in the placenta. So, criteria for diagnosing TAPS, twin anemia polycythemic syndrome, 1 is discordance between the twin-to-twin, between the hemoglobins of the 2 fetuses. Discordance between the hemoglobin of the 2 fetuses at least greater than 8 grams per deciliter. Or reticulocyte count ratio greater than 1.7. Or the presence of small vascular anastomosis less than 1 millimeters in diameter in the placenta. Antenatally, TAPS is diagnosed by the finding of discordant middle cerebral artery. This is the most non-invasive procedure you can do. TAPS, using ultrasound, high resolution ultrasound, to do the middle cerebral artery peak systolic velocities. Mid cerebral artery peak systolic velocity is a non-invasive procedure of making a diagnosis of a twin anemia polycythemia sequence. And the value of the peak systolic volume of more than 1.5 multiples of the median, indicating fetal anemia, is diagnostic. The peak systolic volume of more than 1.5 multiples of the median, indicating fetal anemia, is diagnostic. While in the recipient twin, the peak systolic volume in the mid cerebral artery will be less than 1.0 of the mean of the median. Additional ultrasound findings in TAPS include differences in placenta echogenicity and thickness with a bright thickened section for the donor twin and echolucent thin section of the recipient. In addition, the recipient polycythemic twin may have a starry sky appearance of the liver due to diminished echogenicity of the liver parenchyma. Management modalities include conservative management in mild cases, Halley delivery in the severe cases, and laser ablation of anastomotic vessels, intrauterine transfusion of the anemic twin combined with exchange blood transfusion to dilute the blood of the polycythemic. So the treatment modalities will be conservative, observation, just conservative management, just watchful expectation, Halley delivery in severe cases, laser ablation of the anastomic vessels, intrauterine transfusion of the anemic twin, combined intrauterine transfusion of the anemic twin with partial exchange transfusion to dilute the blood of the polycythemic twin. Twin reverse perfusion sequence is another form of twin-to-twin transfusion syndrome. But this twin reverse arterial sequence called TRAP, the other one is TAPS, this one is TRAP. It arises in monocoronary twins when the two umbilical cords are linked by large arterial anastomosis. When the two umbilical cords in a monocoronary twins are linked by large arterial anastomosis. In normal fetal circulation, the oxygenated blood flows to the placenta for oxygenation via the umbilical artery. But in TRAP, this deoxygenated blood flows in the retrograde fashion via the umbilical anastomotic vessels from the umbilical artery of the pump donor twin to supply the breastfeed. So that's what makes it a very worse condition, because they are from the arterial anastomosis. That's a very worse prognosis. You can see this diagram shows what is happening. You can see the area of linkage. You can see the area of linkage of this is the placenta bed. This is the placenta bed, and this is the cord of the first twin, and this is the cord of the second twin. And you can see the area of arteriovenous anastomosis. Yeah? So I see the area of the arteriovenosis. The donor twin in TRAP eventually develops high output cardiac failure, being responsible for maintaining the circulation of both twins. Parental mortality in the pump twin in untreated case is approximately 50%. Management includes ligation of the umbilical cord of the acardiac twin under fetoscopic guidance. Management includes ligation of the umbilical cord of the acardiac twin under fetoscopic guidance. But the best is for us to make an Halley delivery when this occurs. How do we manage twin pregnancy? Antenatally, frequency of antenatal care visits. Number one, antenatally, frequency of antenatal care visits. Women carrying monochorionic twins should be seen fortnightly from booking until delivery. Should be seen fortnightly from booking until delivery. Monochorionic twins. While those carrying dichorionic twins should be seen 4 weekly until 28 weeks, and thereafter 2 weekly until delivery. And this is because of complications. A lot of complications are seen in monochorionic twins, particularly the twin-to-twin transition syndrome. They are more likely to occur in monochorionic because of the venous anastomosis in the placenta, or arterial anastomosis between the corpus in trap and taps. Then there will be a need for dietary modification apart from the regular visit. When dietary modification, there's an additional calorie requirement of about 300 kilocalories per day, above that is required for single-T pregnancies. This is to allow a good maternal weight gain of at least 16 to 20 kilograms. Dietary modification. So your patients must be encouraged to eat well and with added supplements. Must eat well, with added supplements. Dietary modification, very important. Then nutritional supplementation. Iron supplementation may be increased to about 60 to 120 milligrams, as opposed to 30 to 60 milligrams in single-T pregnancies. Iron supplementation may be increased to 60 to 120 milligrams because the requirement for iron increases with multiple pregnancies, with twin pregnancies and pregnancies of others. And note that the requirement for iron increases from first trimester to second trimester and to third trimester. Usually in single-T pregnancies, in the first trimester, we recommend about 2 milligrams per kilogram of iron, 2 milligrams per kilogram of body iron. And in second trimester, 3 milligrams per kilograms of iron per day. While in the third trimester, it's about 4 milligrams per kilogram body weight of elemental iron per day. So where you have multi-pregnancy, this may be 3 milligrams in the first trimester, 4 milligrams in second trimester, and 5 milligrams per kilogram body weight in the third trimester, so that you can maintain the iron level. Because the woman requires a lot of iron in her body store, and so also the baby requires iron in our whole body, in the liver, in the spleen. And the woman too will also lose blood at the time of delivery. So we need to maintain the iron balance, which is very important in pregnancy. There may be a need to give folate and calcium supplementation as well. Ultrasound assessment. The first trimester ultrasound, when the fetal crown rump length is between 45 to, it equates to a gestation age of between 11 and 13 weeks. So the first ultrasound must be done between 11 and 13 weeks. Some people can still be done between 12 and 15 weeks, but it's more sensitive about this time. And one of the reasons for doing this at this level of 11 and 13 weeks is to be able to determine chorionicity, and nuchal translucency to screen for Down syndrome. To determine chorionicity and nuchal translucency to screen for Down syndrome. Because we have an increased, with multiple pregnancies, we have an increased risk of congenital malformations. For the same reason, an anatomical scan is recommended between 18 and 20 weeks. Anatomical scan is recommended between 18 and 20 weeks, to see and to detect twin-to-twin transfer syndrome, if possible. That's very important. Yes, what's the timing of delivery? Routine bed rest, cervical sacrilege, tocolysis, Arabine pessary, and progesterone do not prevent spontaneous preterm birth in multiple pregnancies and are therefore not recommended. Routine bed rest, the use of cervical sacrilege, tocolysis of the uterus, Arabine pessary, and progesterone administration do not prevent spontaneous preterm birth in multiple gestations and are therefore not recommended. To reduce the risk of fetal death, it is recommended that uncomplicated dichronotic twin pregnancies be delivered between 37 to 38 weeks. Uncomplicated dichronotic twin pregnancies be delivered between 37 to 38 weeks. Uncomplicated monochorionic diamniotic twin pregnancies delivered between 36 to 37 weeks. And triplet pregnancies at 35 weeks after a course of corticosteroids. And these corticosteroids will promote pulmonary maturation. Elective cesarean section between 32 to 33 weeks is recommended for monochorionic monoamniotic twins due to the increased risk of cord accidents in labor in these pregnancies. And remember, a lot of twin-to-twin transfusion syndrome are associated with these monochorionic and monoamniotic twin pregnancies. What are the indications for cesarean section? Indications for cesarean sections. One is monochorionic monoamniotic twin pregnancies. Monochorionic monoamniotic twin pregnancies. Once it's detected in the first trimester, these patients should be booked for an elective cesarean section. Conjoined twins, Siamese twins, they are also, it's important that these fetuses are delivered electively. And once they are delivered electively, there must be a consultation with the neonatal physician or pediatric surgeons to determine when these conjoined twins can be separated. Non-cephalic false twin. For instance, if the leading twin is breech and the second twin is cephalic, cesarean section is the rule. Non-cephalic false twin, e.g., a breech presentation, leading twin breech presentation, second twin cephalic, cesarean section, elective cesarean section. Where there is a significant weight discrepancy between the twins, at least more than 750 grams, particularly if twin B is bigger than twin A. This we see in discordant fetuses of multiple pregnancies. So this should lead us to cesarean section. Expected gestational age less than 32 weeks. Expected gestational age less than 32 weeks, when the expected fetal weight is less than 1,500 grams, we should do an elective cesarean section. Cesarean section is indicated for the usual obstetric reasons, either for medical reasons, presence of eclampsia, resource immunization, and many other indications that we normally do for single-tip pregnancies. But where there is a peculiarity of MCMA, monochorionic monoamniotic, conjoined twins, non-cephalic false twin, significant discrepancy between the two twins, or expected gestational age less than 32 weeks, or expected fetal weight less than 1,500 grams, cesarean section may be done. Cesarean delivery is indicated for the usual obstetric reasons. Intrapartum care. Fourth stage of labor. Informed theater because of risk of emergency resection. Informed anaesthesis for appropriate analgesia, and the gold standard being an epidural analgesia. So in the first stage of labor, informed theater because you may have to recourse to emergency resection, and let the anesthetist be in the know and let them properly give analgesia, appropriate analgesia, the gold standard being epidural analgesia. Delivery should be attended by 2 midwives and 2 neonatologists, 1 each for each twin, as well as an assistant to assist with the delivery. You might need to establish intravenous access with a wide bore cannula and send blood sample for grouping and cross-matching of at least 2 units of blood, owing to increased risk of PPH and emergency contraception, emergency cesarean section. Twin delivery is an indication for continuous electronic fetal monitoring where facilities are available. So the 2 twins must be monitored electronically. Monitor labor pathographically to prevent and detect prolonged labor early. So twin pregnancy must be monitored pathographically to prevent and detect prolonged labor early. Second stage of labor, constitute, label and put up the patient's bedside 2 oxytocin infusions, 1 5 international use oxytocin in 500 ml of dextrosaline for augmentation of uterine contractions. There will be 2 lines, one with 5 international units of oxytocin and the second with 20 international units of oxytocin in 500 ml of normal saline for PPH prophylaxis following delivery of the second twin. Following delivery of the first twin, double clamp quickly the umbilical cord, divide between clamps, and hand over the baby to one of the attending neonatologists. The umbilical cord should be clamped promptly to prevent the second twin of a monochorionic pair from exsanguination. And quickly do a vaginal examination to note the station and presentation of the second twin, as well as presence or absence of the second sac, and rule out cord presentation and prolapse. An assistant should promptly do an abdominal examination to ascertain the lie, the presentation of the second twin, palpate for uterine contractions, and auscultate for fetal heart tone if there is no continuous electronic monitoring. The second twin is at increased risk during delivery because of malpresentation and mal-separation following delivery of the first twin. If uterine contractions wane following delivery of the first twin, allow 5 minutes before commencing augmentation of labor with 5 international units of oxytocin in the first 500 minutes of it, starting at 10 drops per minute. If fetal monitoring suggests fetal well-being, it is necessary that twin B must be delivered within a prescribed time period. If twin B is breech, oblique or transverse, deliver preferably by breech extraction. Breech extraction. Following delivery of the second twin, triple clamp the umbilical cord and divide between 1 clamp on the fetal side and the 2 clamps on the placenta side to differentiate the placenta of the second twin from that of the first. The placenta should be examined by an assistant. The third stage of labor must be managed actively. The third stage of labor must be managed actively. Monitor vital signs, uterine contractions, and perineal pad in the labor ward for 2 hours before transfer to the postnatal ward. And this is very important because majority of them are prone to postpartum hemorrhage. For higher order of multiple pregnancies, more than 2, triplets, quintuplets, yes, maternal and parental morbidity and mortality are higher in this group compared to twins and single pregnancies. The mean gestational age at delivery is 33 weeks for triplets and 31 weeks for quadruplets. Multi-fetal fetal reduction between 10 and 12 weeks should be recommended for quadruplets and higher multiples to lower both maternal and fetal risk. It is recommended that triplets are delivered by elective cesarean section at 35 weeks gestation as the first presenting fetus of triplets in other service. It is recommended that triplets are delivered by elective cesarean section at 35 weeks of gestation, as the first presenting fetus of triplets is older than vertex in about 1/3 of cases. The chances of malpresentation of the second and third triplets is high, and there is difficulty in monitoring 3 fetuses simultaneously. Interval delivery of multiple pregnancies. Interval delivery of multiple pregnancies. This refers to the preterm birth of one of multiple fetuses without immediate delivery of the other fetus for an extended duration to enhance extraterrestrial survival rates of the residual fetuses. This is very common. We have had delays of between 3 to 143 days, with a mean of 44.8 days and median of 35 days have been documented, with significant improvement in parental outcome without a marked increase in maternal complications. For interval delivery, the pregnancy should be below the age of fetal viability, preferably between 20 to 28 weeks at the time of expulsion, delivery of the first of the fetus. The chronicity must be dichloric, trichloronic. The membranes in the remaining gestational sac must be intact, and fetal and maternal monitoring must indicate fetal and maternal well-being. Following delivery of the first fetus, the cord of the liver fetus should be ligated as close as possible to the cervix under strict aseptic conditions, and the placenta left in situ. Parenteral broad-spectrum antibiotics should be administered to prevent infection, and in selected cases, tocolysis and cervical sacrilege may be done so that the pregnancy can be carried over for some time. Corticosteroids will also be administered for fetal lung maturation. Hospital admission until delivery is recommended to enhance early diagnosis and management of perinatal and maternal complications. In conclusion, multiple pregnancy is a high-risk pregnancy because of the higher risk of maternal, fetal, and perinatal complications associated with such pregnancy compared to a single pregnancy. Management of multiple pregnancy requires a multidisciplinary approach if good maternal and perinatal outcomes must be achieved. With good multidisciplinary management of these pregnancies, outcome is satisfactory in the majority of cases. I thank you for listening. And these are the references.